So anyway, so let's go on to the next case. So this is case number 3. And so for those that don't know Collective Minds, I use Collective Minds a lot actually for a lot of my teaching and all the courses that I run. I run courses on radiology seminars. So if you are interested in learning from us on that platform, then please feel free to. We've actually partnered with Collective Minds as well. So they do the kind of the background of the images that you get access to, and then we do the teaching on the side of it as well. And what you can see is that you can download the images. The images don't take that long to download, and there's quite a lot of us right now on this platform, and it's still coming in quite nicely. And then you can just scroll through just like any other PACS viewer that you guys may be aware of. So let's have a look at this one. So what I usually do, and what I'd always recommend for people, is that you do one scroll through. Before you do anything else, just do one scroll through of any CT, all the way down, and go right to the very bottom, and then come all the way back up, and just sort of take in what's going on. And then again, with this platform, you can actually use windowing. So if you press, I think it's going to be 4, you can go to long windows. So that's really good as well. So you get all the windows that you need. So when you see these areas over here, can you see like around here, the lungs don't look very well defined. They kind of look kind of wavy. They almost look like little seagulls, right? So I'll try and draw a seagull for you. So they'll be like a little seagull. If they look like little seagulls, then they've had a lot of breathing artifact that's degrading some of these images. Scrolling further down, you can actually see here there is this sort of kind of haziness in the middle of all those seagulls. So there's a little bit of breathing artifact, but there's haziness here as well. But that would be more in keeping with consolidation. So there is some consolidation as you come further down. And this is more well defined, and you can't see any air bronchograms. For those that don't know what air bronchograms are, in consolidation, you'll have little kind of airways that are not, which are not kind of blocked up by pus or fluid or whatever it is. That's consolidation. But here, that's not consolidation. It's very, very well defined. Looks almost crescenteric-like, and so therefore that would be a pleural effusion. Coming further down, you can start to see more sort of confluent areas where there's less of those kind of like tiny little airways within there. Looks more confluent and more solid. Further down and further down, this feels like almost crescenteric here. So it's probably a small pleural effusion there. And coming further down, it just gets worse and worse for this patient, unfortunately. It looks like they've got a combination of quite significant consolidation. So someone's done really well there, and also start to wonder, well, okay, is there something else going on? Because, okay, you do have extensive consolidation, but some of these don't really look like consolidation or like focal consolidation, because normally with consolidation, you get sort of kind of wavy, irregular shaped things, but some of these actually look a little bit circular. Right. And especially because at the lower lobes, you've got to start wondering, okay, we've got multiple lower lobe lesions, right? And they look very circular, very, very spherical. So that one there, and that one there. And with a malignancy anyway, you'd be more likely to get multiple comorbid metastases in the lower lobes, and that's because of the way the blood flow is. Because if someone's standing around, in theory, the infected blood would be in the lower areas of the lungs, and that's where you get more of your malignancies. You get multiple comorbid metastases in the lower lobes. So that's something that we are worried about. Now, septic emboli could happen. Usually, you'd be looking at sort of cavities. I don't think we see much in the way of cavities, and they wouldn't be so predominantly in the lower lobes. They'd be generally quite well defined, and they'd be all over the place. And also, when I was just going to mention something quickly, is that the idea of the blood flow kind of going downwards is why you get some apical scarring usually, which is kind of normal because over time the APCs don't get as much blood and stuff as they usually would, and they start to kind of fibrose a bit. You do have this calcified granuloma here though, which is one thing. So the other thing you need to do with any of these cases is, so at the moment we're thinking, okay, it could be, yeah, multifocal pneumonitis. Yeah, it could be. It could be a background of cardiac failure as well because these bilateral pleural effusions, right? Then you also got to try and see whether you can find any lymph nodes. And it can be difficult in these non-enhanced studies. And this is a non-enhanced study because if you look at the aorta, that looks very, very similar in terms of its density towards the pleural effusion and everything else. So we can't really go with the idea that this is not a contrast enhanced study. But can you see here this thing over here? So I'm going to try and point it out again. That little thing there, if you kind of come up, it disappears, and come down and up, it disappears and disappears, right? So that actually looks different, separate from the vessel. So it does look like there is an enlarged lymph node around there. Hyalo-wise, it can be a bit more difficult because again, it's a non-contrast study. Someone has said, could it be lymphangitis? Yeah, you can have lymphangitis, but generally speaking, when you look at the lungs, they look like nets, like a proper net. So with lymphangitis, you're saying there's too much lymph, and you normally get sort of thickened thickened interlobular septi. But here, we don't have any thickened interlobular septi. So we're kind of going between, okay, we're kind of gearing towards this is probably going to be infection, maybe background of cardiac failure, right? Because you've got bilateral pleural effusions. Also, there could be parapneumonic effusions as well, because someone could have effusions as a result of infection in the first place. But then also, we're all radiologists right now anyway. We have to look at everything else. So supraclavicular wise, yeah, the thyroid may be slightly enlarged, but not much else is going on. The axilla, they don't look like they have anything else going on either. There's no enlarged lymph nodes. So you'd be looking for lymph nodes in the armpits over here. So, and yeah, so someone said could be metastatic lobe. Yes, it could be, but I don't think we can convincingly say that we've got a focal primary because the primary would usually be the big one, very, very obvious, and then you'd have all these small ones. So we've got to still think about what else it could be. So then we have a look at the liver, and it's a non-contrast study. I get it. Like it's not going to be entirely easy to try and figure out what's going on with regards to the kidney and the liver. But then the liver looks okay. The pancreas, sometimes you get pancreatic malignancies, but that looks kind of fatty and kind of slightly nodular, but that looks all right. No focal lesions. The spleen looks okay. And the adrenals, which are here and here, they look okay as well. But yeah, someone's hit the nail on the head. So if you come further, oh, someone said, is it a pericardial effusion? It's come up here. So yeah, you do have a little bit of fluid. It's not something I'd be too worried about. It's very, very thin, but not enough to be thinking they've got some sort of pleurisy or anything like that. But someone has managed to find something quite abnormal. Can you see that? So what about the hepatic flexure? So let's go. Hepatic flexure, that's going to be here, isn't it? So you come across this way, and actually that looks okay. And you go across, it looks like it's going this way, this way. Don't have the entire thing. And then we're all the way to the splenic flexure. But this is what's abnormal. Can you see this? Yeah, this exactly. People have found it now. So I'm going to draw that out. This here is not normal. This is a very large lesion emerging from the anterior aspect of the mid right kidney. Looks very, very ill-defined, maybe a tiny calcification or something within there because it's a non-contrast study and you've got some hyperdense areas. But there's also some fat stranding located within this region, right? So now you're thinking, okay, this looks like a primary right cell, yeah, an RCC, right? And then you've got to be a bit more careful now because you've got multiple potentially it could be a couple of things, right? You could have a multiple pulmonary metastases on a background. No, you could have pulmonary infection, so you could have consolidation and infection on a background of metastatic disease. That's entirely possible. But because we've seen these multiple, because we've seen that primary lesion located within the kidney, that's when you've got to start worrying that there is, these are going to be potentially multiple metastases. And I'm going to show you something else about the platform, which I think is really impressive, is that you can actually do all the stuff that you normally do, do coronal, do axials, all from the same CT that you'd have in your work computers, which is why it's been so good for us to be able to teach people and not just show people the answers, but how to get to the answers too. And so now here we've got to, because we know this patient's got malignancy, we've got to really try and see if there's any sort of destructive bone lesion. And you come to this area over here. What's people saying? Right renal vein distended. Yeah, so yeah, I was going to go on to that. That's a good point. So some people may worry that this could be, this over here could be a focal metastatic lesion. But when you look at it, they look kind of linear and very straw-like. And so when you've got straw-like fatty areas, it's probably going to be a hemangioma. Exactly right. And then just got to still look there. You've got to really look. So again, that could be hemangioma. It looks very linear and hypodense. And I haven't seen any sort of abnormal abnormalities with regards to the rest of the bones. So someone said that which is actually a very good point. I have to say though, this is a non-contrast study. So unless it's blindingly obvious, I wouldn't really go with it. So one thing someone said is that the renal vein looks slightly distended. And that's actually one of the things that can happen with an RCC, that you get extension of the renal cell cancer into the renal vein. So that's entirely possible, but I would be hesitant. I may mention it, but then at the end of the day, there's no point in trying to be too much of a hero. You see the RCC, you're worried about pulmonary metastases, and you're going to end up getting a contrast and unstudied for full staging, right? You're going to do the abdo-pelvis and CT head as well, just to make sure there's no intracranial metastases. Now, the reason why I thought this was quite good is that if you weren't going all the way through, like if you just sort of scroll through, you think, okay, cool, looks like infection, leave it at that, then you're going to leave this person with infection. But that's what I noticed, that like the last cut, the last slice could slice your career essentially, because that literally is like the last what 4 or 5 slices where there's this clearly abnormal lesion which completely changes the trajectory of the entire clinical picture. So this person could go home with antibiotics or get what they actually need, which is probably going to be full staging scan, potentially biopsy, or excision and referral to urology and all that kind of thing. And so you can see why it's very, very important that in radiology anyway, I guess anyone who is doing any sort of imaging, you really have to look at every little thing because this person actually, from what I remember, came in with um, it was, I mean, it was a non-contrast study because they thought it was non-healing infection or something. So that's why they did this, and it turned out it was actually the RCC was probably causing most of the problems. Right. So yeah, well done. A lot of people came up with some really interesting stuff there. TB infection. Yeah, I would probably not go with TB infection on this one because it's such an abnormal looking lesion located within that kidney. They were an older person as well. I don't think they fit the demographic for TB. I mean, it could be. Of course, you never say never because I think TB is one of those things that like could literally do anything. And I think sarcoid as well. Sarcoid can just look really weird sometimes. So you can't 100% say no way. But I think on balance, you're probably going to have to go with it being, yeah, it's not, it's probably less likely.